Hello and welcome to the Journal. I'm Steve Kendall. Every year more than 3 million people have knee replacement services done. Increasingly, this surgery is done using robotics. It's evolved over time. Joining us from the Wood County Hospital to talk about this procedure and especially the new evolution in robotics is Dr. Carlos Gomez. Dr. Gomez, welcome to the Journal. Thank you for being here to talk about this. Kind of talk us through how knee replacement surgery has evolved since it first began, because obviously done a lot differently 15, 20, 30 years ago, but it's even changed a lot just in the past couple of years. So talk about that evolution a little bit.
Absolutely. Thank you for having me today,
Sure.
Steve. We have been doing total joint replacement for about 30 years. And through the years, we've been noticing improvement in the technology. Initially, we were able to use just some tools that were able to be used for every single patient. And I have a little sample that you can see how we initially used big rods to put inside the bones to try to get the alignment that we need for those patients while we were doing the procedure. So I've been here in Wood County Hospital about 15 years. In the past 12, we try to bring the latest technology in joint replacement. So initially, we were doing MRIs or CT scans to make a patient-specific type of total knee replacement. So in the first, as I said, we made these jigs with the studies, with the MRI and with the CT scan, and make these jigs that were used, one for the femur, one for the tibia, and we were able to make the perfect cuts to give that patient a specific knee. You know, all the bones are different, and so we need to make sure they were specific for that patient. Through the years, that changed. And last year, we started at Wood County Hospital bringing robotics. Robotics in orthopedic have been around 20 years. And with the first generation up to the fourth generation is what we were able to acquire here in Northwest Ohio. The first hospital that had it in this area. And me, the one that did the first robotic fourth generation type of knee. It's been very exciting. The changes that we've seen through the years is, as I said before, making these jigs. This process takes about 6 weeks.
Wow.
With the latest technology, we have a robot that we can do in 4 minutes what it takes 6 weeks
used to take 6 weeks to do. Oh
Absolutely.
My gosh.
The advantage of it is we don't have to do any extra tests, no MRIs, no CT scans, so we don't have to expose the patients to other type of studies. And the robot will do it in real time.
Wow.
So in 4 minutes, we can arrange using this arrays that we put in the patient, as well as we have to document all our information through a camera that is 5 times faster than a hummingbird wing. It's very fast. So it takes 1,000 pictures per second, and we can document our knee into the system. And in those 4 minutes, we see the alignment that the patient presents with, and we can program that to make sure we get the alignment that the patient needs.
Because as you said, this really personalized, because everybody, you know, we all have knees, but everybody's knee is a little bit different. You said alignment, those sort of things. And I guess from the patient's perspective, that shaves so much more time off that they get their knee replaced or their joint replaced and get rid of the reason why they're doing it. The pain, everything can go away faster. They can get to physical therapy faster, all those sort of things. So it really shortens that time frame, not only for you, but for the patient as well.
Absolutely. They don't have to wait 6 weeks. But back then, when they needed to wait 6 weeks, we have those patients in rehab so they could get stronger, probably get a little bit better motion. And those patients definitely bounce back a lot faster. But definitely with this new technology, we are able to be more accurate. We can decrease the time of stay in the hospital, and we can have smaller incisions and also a faster recovery.
So a lot less invasive and a lot better all the way around from every aspect of it. When you talked about the way we used to do it, the older style thing, that replacement, how long would that be a permanent replacement, or would that be something that would last 15 years, 20 years? What was the life expectancy of an old style replacement?
At that point, FDA is the one who rules that and says, usually it's about 10 to 15 years. But not only the techniques have evolved, but also the quality of the implants. So for instance, with this prosthesis, the company has put a lot of effort and money into develop new techniques and also materials. So when we have a knee replacement, we have metal in the femur, metal in the tibia, and a piece of plastic in the middle.
Okay.
Back in the day, that was a plastic that would start to wear off. So the release of free radicals is what it makes that plastic to wear off.
Ah, okay.
Nowadays, the addition of vitamin D into the poly, the plastic, has helped on decrease wear and tear 50% compared to the old type of material that we use. So the longevity of this product is going to be a lot better, and those knees are going to be better. We have good studies right now that show that the longevity can be, that patient can be good forever with that knee. Again, it depends on use and abuse.
Sure.
But we have good results so far, and with the literature that we have.
Now, has there been a change? Because I know that, at least from the layman's perspective, they used to say, well, let's hold off on doing a joint replacement because we want this to last the rest of your life, which means let's wait until you're 60, 65, whatever it would be. That's not the case now, because if you could replace my knee at age 40, theoretically you're saying that might last me the rest of my life, given the new materials and the techniques and everything that are now available.
Steve, great point. Because that was the problem before. We were thinking that these materials were going to last, and we've learned through the studies that they do last. Having the latest technology obviously is going to make the longevity a little longer. Age at this point is not an issue.
Great.
It's all about quality of life. And I always tell my patients, if we have done everything, you've done therapy, you've had injections, you have lost some weight, and you're still having pain, but your quality of life is not there, it's time to make a change. So for instance, I've done a total knee replacement in a 40-year-old. I've done a total knee replacement in a 94-year-old. And they do well. And so age at this point is not. I think the main thing for our patients is quality of life. And I think we achieve that with that.
Yeah, and it's a good point too, because the other aspect is, as you get older, surgery becomes somewhat more problematic. This removes that invasive too. It makes it easier for someone is on that end of the scale versus maybe the younger end of the scale for this. So it works all the way around for everybody. That's incredible. That's incredible.
Through the process, we've been doing other things that have helped on the patient with pain, which you touched earlier. So on those patients, we do a nerve block of the leg, and they do general or spinal. We prefer spinal because the patients are more awake with less nausea after the procedure. And then at the end, we have a product that I'm the only one using in Northwest Ohio. It's a combination of a medication that is an anti-inflammatory with a long-lasting anesthetic that we pour in the back of the knee. And it stays there for 72 hours. It makes that transition very smooth for our patients. When the nerve blocks go away, they still have that pain medication inside the knee before we close them. And we have noticed from our pharmacy department that we use less narcotics in those patients as well.
And that's always a benefit too.
Is a huge benefit nowadays, absolutely.
Okay, good. Well, we'll talk more in just a minute. Back in just a moment with Dr. Carlos Gomez from Wood County Hospital. We're talking joint replacement surgery, the new robotic techniques, and focusing on knee replacement. Back in just a moment here on The Journal. Thank you for staying with us on The Journal. We're joined in this segment by Eric Avers, a physical therapist at Wood County Hospital, and also Dr. Carlos Gomez, orthopedic surgeon there. Dr. Gomez, when we left that last segment, you were talking about the fact where we've gone through the procedure, the patient's been getting anti-inflammatories, pain medication before you complete the procedure finished. So talk about what happens as you get everything in place. You've got the patient now ready to turn over. So what happens as you complete that process? And then we'll talk with Eric about, he picks it up then as physical therapy thoughts. So what are the final stages of your role in this as we talk about the procedure?
Right, Steve. It's an effort of team work. And I round my patients right after surgery, make sure that everything is fine, talk to the families, give a little, talk about what to expect. Definitely, they will go back to the floor, and because of the blocks, we don't recommend them to be up. So they stay in bed, and the next morning, the first thing they do is they have breakfast, a pain pill, and for dessert, they'll have therapy. So therapy is important for them, which they do in the morning, and they work with our team, a physical therapist, and at noon, they'll come back so they can do steps. After that, the patient goes home about 3 p.m. The
Wow,
next day of the
so
surgery.
you're in and out of there really within a real short period of time. Okay.
We make sure that our girls also arrange for a follow-up so they can see Eric in rehab.
Yeah, yeah. So literally the day that next morning they're up and starting to move around a little bit on this new replacement joint.
Yeah, there are big cities where they say, well, we want to send them the same day. I think that is a great idea, but I want to do everything in my power to make sure that we can decrease complications with them. I want to make sure we give them 3 doses of antibiotics. I want to make sure the pain is under control, and I want to make sure they start therapy the next morning.
Yeah.
Yeah.
Yeah. So we've gotten through the procedure and you've released them, and now, of course, sometimes when people say physical therapy, people could get a little shaky because obviously it means there's going to be some work ahead. So talk about this process, because obviously since the surgery procedure has been a lot less invasive and much more customized to the individual patient, hopefully that makes your job a little bit easier.
Absolutely. So we try to make it as streamlined as we can from when they leave the hospital. Within another couple of days, we get them into outpatient. We've found, since we've kind of incorporated some of these newer procedures, things are a lot easier for us. They're a lot easier on the patient. There's less pain. We're able to get the outcomes that we need a lot easier and a lot quicker without having to burn up as much insurance coverage. So that first week that we've had surgery, we get them in, we take some initial measurements of their surgical leg compared to their non-surgical leg, kind of set some goals with the patient, send them home that first day with a few more exercises that they need to be working on at home, get them scheduled then for 4 to 6 weeks and kind of hopefully get them back to where they need to be within that time range generally for the most part.
Yeah. Now, you mentioned something, so when you measure both legs, is there an expectation that it will be slightly different, or what's the purpose of that?
Typically, no.
Okay.
We get
that's
some,
good to know.
That's
a good thing. Yeah.
We get some people who the right leg's the bad one, but the left one's also bad, and I'm going to get the right one done first, and I got to have so you don't want to compare to an already bad leg, but we kind of have a general idea. We want to be able to get the knee all the way straight, and we want to be able to get roughly 115, 120 degrees of bending out of the knee so that person can descend stairs properly, can get up and down off of a low toilet, a low couch, those kind of things. That's kind of the general range of motion that you need to function without any issues. So that's
the goal, and hopefully now you can you go beyond that and get a larger range of motion, but that's what you really need to do all the normal things that we're used to doing.
Yep, that's kind of the bare minimum, and we are seeing younger and younger people that are having these surgeries now, and they have some higher level goals that require more range of motion, and if that's the case, no problem.
Well, and that raises an interesting point, because we talked about the fact that you can do them now earlier, you can do them later.
Correct.
How does that, when you deal with say a 40-year-old, you sort of just touched on that, is the plan obviously different for a 40-year-old than say a 65-year-old?
Absolutely.
Okay.
We try to individualize the goals. We talk about that with every patient. What are you trying to get out of this? Are you trying to just get back to recreational exercise? Are you trying to do something higher level? Are you chasing grandkids around? We have that conversation the first day and kind of set goals based on that.
Yeah. And obviously you provide feedback to Dr. Gomez, and then you look at what's coming out of physical therapy and work with Eric or his counterparts to say, we need to do a little more, or we should be seeing a different result, or we're hoping for a different result than maybe what we're seeing. But most times it probably goes well, I'm assuming.
Yeah, definitely we do work together very well, because if they seem to find something that they're not happy with, they communicate with me immediately, and we can address whatever needs to be addressed in that patient. We like to get that motion, as Eric said, 0 to 120 with a minimum of maybe 110, so they can be functional.
Sure.
But if with time they're not able to get to that point, then we have to direct the program another way, just to make sure we achieve and get to what we need to achieve on those patients, yes.
Yeah. Now, do you ever encounter, I know because obviously someone who's had this surgery, is there ever reluctance on their part to test the joint? Like, well, do I really want to move it? Because, I'm not sure. I mean, there's probably a little concern, like, well, maybe is it safe to move it? Do I want to move it? I mean, how do you deal with that from a psychological point of view? It's like, well, it feels okay, but I don't want to break it right out of the box. So
I can tell you, Dr. Gomez, is already on top of that before the patient ever even gets to us. He explains everything went well. We made sure the knee could go all the way straight. It could bend and everything's nice and stable. So we basically just have to explain that a little bit of pain is okay. It generally goes away within a week or two for the most part. Right. But it's okay. The alternative, if we don't get this motion back, is we're not going to have the outcome that we want to have. So that is a pretty good motivational tool for people to kind of push themselves a little bit.
Yeah, because that's good to know, because obviously it's like anything new. The first time you want to try it, it's like, well, do I really want to see if I can push it to that limit? And obviously, as you said, there's going to, with any kind of rehabilitation or any kind of physical therapy, there's going to be some pain because you're doing some new things with a new device. So that is something to take into consideration. But it's good to know that you've prepped them enough that they go, okay, it's okay to do what Eric is asking them to do.
The expectations are set before. So we talk to them before surgery, throughout surgery, and after surgery. So we work as a team to make sure we achieve that goal. And it's definitely important to show them that motivation is important. It's not about what the surgeon does. It's about a whole team effort where we have the surgeon, we have the patient, we have physical therapy, and we all work together to get to the goal that we set from the get-go.
Yeah, and that's a good point, because your thing is to make sure when they leave they have the functionality that they need, if not more so. So that's a good thing.
Yeah, we try to make sure that everybody, when they're done with physical therapy, they've got a home program. It's not done after that month, 2 months of physical therapy. You've got some things that you need to continue to work on to get your strength all the way back where you want it to be. And we try to make sure that everybody's got pictures and they've got videos and they've got bands and weights and everything else that they need to be able to continue to work on it.
So it's pretty comprehensive.
One of the things that I like to do right after surgery is to take a picture of that knee completely straight and completely bent, so we can show the patients that they can do that. And even though they say, well, I was asleep there, or I was under, whatever, still they can do that.
They know they can do that.
And they keep that picture so they can look at it and say, I have a goal, we need to keep going on it.
And it's doable, and I'm not going to hurt myself doing it.
Absolutely.
Okay, we're going to be joined by one of your patients here in the next segment. So back in just a moment here on the Journal with Dr. Carlos Gomez, physical therapist Eric Avers, and a patient who's gone through this procedure, and we'll talk with us about that, Helen Frobase. Back in just a moment here on the Journal. Thank you for staying with us here on the Journal. We're talking about knee replacement. Wood County Hospital with a new robotic situation, Generation 4 knee replacement robot. And we're joined in this segment by a person who has just gone through this procedure, Helen Frobase. We want to thank you for being here.
My pleasure.
Talk a little about how you found out about this, how you got through it, and then we can talk about how it's worked out and that sort of thing. So how did this all start with you to approach Dr. Gomez to talk about getting this procedure done?
Well, it started, my older brother, who's 16 years older than I am, had his knee replaced and just was going on and on, raving about Dr. Gomez, So I thought, well, I'll go in and get a baseline. I'm 16 years younger and I probably need a partial, but I'd been dealing with a lot of pain and swelling for years, and I needed a total knee. So I went ahead and had that done. And that was in December of 19. And then just almost a year ago, I had the other side done. So I have the original way, and then I also have the robotic knee as well.
So you can kind of give us a comparison of the two firsthand. Wow, okay.
I know he mentioned the picture that we all get at the end, and that was seeing that picture with my knee bent, like when I was 10 years old. It was my goal, to reach that in physical therapy.
Yeah.
So.
Yeah. Now, you talked about the fact you got one done and then the other. How much difference was there in the two procedures? Can you tell a definite difference between the original one and what you had to go through to get it back to where you wanted to be, and then doing it with the new procedure?
I think the second one with the robotics, I think it was less hospital time, and I think the recuperation was quicker, and the rehab and everything I think was quicker, and I ended up with a better degree of bend than with the first one.
Yeah, yeah. And Eric, from your perspective, when you were dealing with the ways we've done this over time versus now, that's obviously changed the way you approach the physical therapy part of it in the plan as well, right?
Yeah, it's made things considerably easier for us. We don't have to be We don't have to be as mean. Sometimes we get a reputation from people, physical.
Well, I wasn't going to mention
torture.
that, but you did. Okay, all right.
Yeah. So we I don't think we have to be as mean anymore.
No.
We can be a little more gentle, and things just kind of come along a little bit easier than they have in the past.
And that makes it better for you too,
Absolutely.
because nobody wants to be the mean guy
Absolutely,
or whatever.
yeah.
So that's a good thing. Dr. Gomez, when you talk with people who are considering this, you've talked about the advantage, but talk again about the main points, why this is a much easier procedure and something that people maybe shouldn't put off because they're worried about, well, this is going to be really invasive and the rehabilitation is going to be a long time and the PT is going to be tough and Eric's going to be mean to me and that kind of thing. So talk a little about how when someone comes in and says, I'm thinking about this, I've heard horror stories.
Yeah.
How do you talk them through that and explain to them that what they've heard isn't exactly anything close to what's about to happen?
Unfortunately, yes. We have patients that come with very horrific stories about total knee replacement, and our job is to show them what they have and what we can do for them. I think that using the latest technology has helped us out to be more accurate, to have less time on the patients in the hospital with less pain and a faster recovery. So that is something they want. We don't push them into anything they don't want. Sure. We are there to explain them, and they make up their mind. Again, as I said before, they want a change on their quality of life, and we can provide that with the latest technology.
Yeah. And Helen, when obviously you've had the experience of doing both knees, because you hear stories where people say, well, after I got one done, I'm not going to do the other one. But in your case, the first one was successful and it was full scale, everything worked out fine, but that encouraged you probably then to do the second one. It turns out with the newer techniques, the robotic techniques, made it even easier.
Yeah, and it was like, I mean, you hear people say this all the time, but it's true. Why didn't I do this sooner? Honestly. Yeah. And afterwards, I know a lot of people may not believe it, but when I went home, I had no pain.
Wow.
I had no pain.
And that's quite a change from the way it was
and I think
before,
it's important. I mean, it takes two to do this whole thing. It takes, the patient and the doctor as well. But with the patient, I mean, it's best, I think. Do you notice, Eric, if you have patients come in that have maybe done a little work ahead of time?
Absolutely, it makes a huge difference.
Because with my first one, I didn't do much, but with the second one, I prepared.
Yeah, and what would be the kind of things that people, if they're looking at this, you would recommend that they do as preparation for the process to make the end of it, the other side of it, go better?
It doesn't need to be anything intense. I'll tell people to get on a stationary bike, keep the seat nice and high, avoid creating pain, but just get some range of motion in the knee as much as you can. Do some walking, do some just gentle leg lifts, trying to get your muscles a little bit stronger. It's going to make things a lot easier afterwards if you have that leg in a little bit better shape.
And then probably even the cardio part of it too to help with all of that as well. Now, question real quick. If I've had, let's say, a knee replacement some time ago, and I'm with the older technology, and I'm due for now, that one has to be replaced. My original model now is obsolete, out of date. It's not functioning. I want it to. Is this process work the same way with something like that?
No.
That isn't as applicable. No. Okay, all right.
This is for
a new natural.
New
okay, gotcha.
Yeah,
okay, yeah. What would, now, just for the sake of, what would be if I came in and said, look, I've had both knees replaced 20 years ago, what would you recommend I do then at that point? Is there something I can do or not?
So, we examine the patient, see where the problem is. Sometimes we see the patients are still weak and they just need a little bit of therapy.
Okay.
Or we take an x-ray and make sure that if there's no loosening of the components that have been cemented there or that can be changed. So there are options. But definitely, the robotic knee at this point is only used for a new knee.
In initial replacements,
Absolutely.
yeah. Now, if someone wants to find out more about this, what's the easiest way for them to get in touch with your office and say, hey, I'm interested in talking with you about that? What's the simplest way for them to do that?
We're going to give you our number.
All right. Okay.
And we always are telling our community we do a seminar every other month in the hospital, in the hospital meeting rooms. And we educate our community. We got patients from Ohio, from Michigan, from Indiana, from all over the place, and they want to get educated about it. Again, as I said, we're the first ones with this technology, so we got to tell the people out there that we have it and we're able to provide the best care they can get.
Yeah, and you mentioned that in the first segment that people would say, gee, you know, they wouldn't immediately think of Bowling Green, Ohio as having this kind of technology, but you said you were among the first and are still among the very few that do it, and there is nobody else really. You mentioned that, you know, larger institutions like Ohio State Medical or Medical, they're not at this level yet with this generation 4 robotics.
I think the studies are going to start showing that we are able to be do in very good way our total knee replacements with being consistent in what we do and with good results. So they'll be able to in the near future to be on board as well.
Okay, so what number should they call?
419-435-3072.
Okay, and they can get in touch with you and then and have the outcomes like you've had, which are really, really good. That's good to know. And it's good to know that in our own community locally, we have the ability to go in and have this done and not have to travel someplace, because sometimes people put that off too because they have to travel 100 miles, several hours away to do it, and that can make people reluctant. So it's good to know it's right here, really, right in the neighborhood. That's good to know. So Dr. Carlos Gomez, thank you so much. Eric Avers, physical therapist, thank you. And Helen Frobase, thank you for coming on and talking to you about us. And Helen, we're glad everything's going well for you. And and it will continue to. So thank you so much.
Thank you, Steve.
Thank you. You can check us out at WBGU.org. Of course, you can watch us each week on WBGU PBS. We will see you again next time. Good night and good luck.